Motor neurography. The performance of the motor neurography is basically equal for all nerves that are available for this examination. Therefore, it is recommended to firstly analyze the examination by using the median nerve as an example. The techniques shown and described herein are essentially repeated in all other nerves, especially when it comes to the basic application of stimulation and recording electrodes, as well as the method of distance measurement. Motor neurography of median nerve. The instrument adjustments for the motor neurography of the median nerve should be selected as follows. Amplification, 2 mV per division. Time base, 5 milliseconds per division. Stimulus duration, 200 microseconds. The limiting frequencies at Neurowerk EMG have been stored in the setup settings and cannot be directly changed. Obviously, the device settings should be configured to suit respective diagnostic requirements. The different or active electrode is placed precisely above the muscle venter of the abductor pollicis brevis muscle. The electrode position is determined by abducting the thumb maximally. The indifferent or reference electrode is attached to the front thumb joint. The electrodes can be secured more effectively if the skin is degreased prior to application. The ground electrode is fixed proximally from the recording electrodes. It should be noted that the ground electrode is always moistened and fastened tightly. Firstly, the median nerve is stimulated distally, and this occurs directly behind the wrist. Therefore, the cathode, the so-called minus electrode, is located distally, which means that it is directed toward the target muscle. The distance from the cathode to the active reference electrode stimulation shall amount to exactly 7 centimeters. This enables comparison of the diacritic important value of the distal motor latency with standard values. When using metal pins, it is necessary to apply a little bit of paste to the pins. Felts should be kept moist to reduce contact resistance between the electrode and skin. To avoid large stimulus artifacts, degreasing the skin might also be useful. The stimulation starts with low stimulus intensity and increases slowly, while stimuli are triggered manually as single stimuli. If the stimulation electrode is positioned correctly, a motor potential can be registered with a stimulus intensity starting from approximately 3 mA. It should be noted that the stimulation electrode is pressed firmly on the nerve, otherwise only the superficial skin is stimulated. The stimulation intensity increases through repeated stimulation triggering until the amplitude of the muscle potential stops rising. This results in the so-called supramaximal stimulus intensity being reached. For good measure, the stimulus intensity becomes increased by another 20%. This current intensity should always be achieved, as it is only then that all motor nerve fibers will be stimulated. A further increase in stimulus intensity is not necessary and does not cause a rise in the response amplitude. If the appointed amplifier sensitivity is too large or too small, it is recommended that the sensitivity be adjusted so that the muscle action potential occupies an appropriate place on the monitor. The position of the stimulus cathode should be marked for subsequently defined the nerve conduction velocity. To determine the nerve conduction velocity in the forearm, the stimulation of the median nerve is repeated inside the antecubital fossa, ulnar of the brachial artery. In this way, it is changed into the next measurement sequence on the monitor. In this instance, the nerve is often hard to find as it can roll away under the push of the electrode. The patient can help the examination process by indicating the feeling of the stimulation in the destination area of the median nerve inside the hand. In all probability, the current intensity has to be selected at a higher level in order to achieve supramaximal stimulation. The stimulation electrode should also be positioned across the nerve. Attention should be paid to ensure that the amplitude and shape of the compound action potential is similar to that of distal stimulation, subject to physiological conditions. The marking of the stimulation electrode's position is also necessary. It may be necessary to also stimulate the median nerve proximally inside the medial bicipital groove or in the axilla. For this purpose, either an additional measurement sequence is inserted, or the program should already be pre-configured, or 3 measurement sequences. When measuring in pathological conditions or very strong arms, it may be the case that the maximum current intensity is not sufficient to stimulate the nerve supramaximally. In such instances, it may be necessary to prolong the duration of the stimulation impulse to increase the intensity of the applied current. To precisely determine the distance between the stimulation points, we have marked the position of the cathode of the stimulation electrode with a waterproof pen. Following this, the distance between both points is measured and entered in the results table on the examination monitor. The nerve conduction velocity is automatically calculated by the device from the difference of both latencies and the distance between the 2 electrodes. As an option, the surface temperature of skin can be displayed by using a temperature sensor. It should be noted that the nerve conduction velocity changes depending on temperature. Usually, the device places the marker of latencies and amplitudes exactly by default. However, if due to pathological conditions or standard modifications this is not the case, markers need to be corrected manually to ensure that precise information is provided regarding nerve conduction velocities and amplitudes. Motor neurography of the ulnar nerve. On the motor ulnar neurography, the different or active electrode is positioned above the venter of the muscle of the hypothenar. This is the so-called abductor digiti minimi muscle. The precise electrode position on the hypothenar is determined by abducting the little finger maximally. The indifferent or reference electrode is attached to the anterior little finger joint. The ground electrode is fixed proximally from the recording electrodes. Initially, the ulnar nerve is stimulated distally, and this occurs right behind the wrist. The nerve conduction velocity of the ulnar nerve needs to be measured fractionally in this area due to the frequent bottlenecks in the ulnar sulcus. Therefore, the stimulation in this section of nerves initially takes place distally to the sulcus and then proximally to the sulcus. The distal stimulation often causes difficulties, which is due to the fact that the nerve runs very deep. It should be noted that it is necessary to work with a relatively high current intensity. The proximal stimulation is usually handled in good order as the nerves run flat below the skin. It may be necessary to also stimulate the ulnar nerve in the axilla. The nerve conduction velocity is calculated by separately measuring the stimulation distances in the forearm, as well as in the sulcus, and possibly in the upper arm section, and then entering the results in the table. Attention should be paid to ensure that the distance measurement in the sulcus section is performed in the same arm position as where the stimulation was made. If there is a faulty measurement in the relatively short sulcus section by a few millimeters, a large miscalculation of the nerve conduction velocity can occur. This might lead to an incorrect pathological result being shown. Motor neurography of the radial nerve. In the motor neurography of the radial nerve, and following this examination method, the different or active recording electrode is positioned above the venter of the abductor pollicis longus muscle. Examining the motor neurography of the radial nerve is more difficult than the neurography of the median or ulnar nerve due to the course of the nerve. The exact electrode position is determined by the maximal splaying out of the thumb. The indifferent or reference electrode is attached to the tendon of the muscle. The ground electrode is mounted to the right, proximally from the recording electrodes. Initially, the distal stimulation of the radial nerve takes place on the lateral antecubital fossa, medially to the brachioradialis. In this instance, you might have to search for a while longer, as the nerve is located below the muscle. Frequently, a strong pushing on the nerves and the prolongation of the stimulus impulse to 500 microseconds may help matters. After a supramaximal stimulated potential is recorded, you must not forget to mark the stimulation point. The proximal stimulation of the radial nerve takes place at the lateral side of the middle of the upper arm. This stimulation should not cause any difficulties due to its easy-to-reach course of the nerve inside the radial sulcus. The radial nerve can be stimulated axillary in the ulterior axilla ruga. It may be necessary to correct the distal motor latency marker manually if the automatic marker was positioned incorrectly as a consequence of an increased stimulus artifact. The nerve conduction velocity is calculated by measuring the stimulation distances between the distal and proximal stimulation and entering the results in the table. In regard to the evaluation of the distal motor latency, the distance between distal stimulation and the reference electrode is also important. Motor neurography of the tibial nerve. The recording of muscle potentials following motor tibial stimulation takes place at the abductor hallucis muscle. This involves the indifferent electrode being attached to the first joint of the big toe. The ground electrode is fixed proximally from the recording electrodes. The distal stimulation takes place above the course of the tibial nerve behind the medial malleolus. The proximal stimulation occurs just slightly laterally to the center of the knee hollow. This results in the stimulation electrode being pressed firmly into the back of the popliteal fossa. Due to the difficult stimulation in the knee hollow, an amplitude evaluation of the proximal inducted muscle potential should take place in a restrained manner. The nerve conduction velocity is calculated by measuring the stimulation distances in the lower leg and entering the results in the table. Motor neurography of the peroneal nerve. The peroneal nerve splits up below the head of the fibula into the deep peroneal nerve and the superficial peroneal nerve. The examination of the deep peroneal nerve is shown here. In the motor neurography of the peroneal nerve, the different or active electrode is positioned above the extensor digitorum brevis muscle. The indifferent or reference electrode is attached to the first joint of the little toe. The ground electrode is fixed proximally from the recording electrodes. The distal stimulation initially occurs above the ankle, laterally to the tendon of the tibialis anterior muscle. Damage to the peroneal nerve frequently occurs in the region of the head of the fibula. Therefore, the proximal stimulation should be executed distally as well as proximally to the fibula head. The stimulation that is executed distally to the head might be difficult, as is the case with the ulnar nerve. This is because of the low-lying nerve. Therefore, the stimulation should take place close to the fibula head. The proximal stimulation, that is medial to the tendon of the biceps femoris muscle, does not cause difficulties. This is because nerves are running flatly below the skin. The nerve conduction velocity is calculated by measuring the stimulation distances separately in the region of the lower leg, as well as those of the fibula head, and then entering the results in the table. Attention should be paid to ensure that the distance measurement in the proximal section has to be performed in the same leg position as that of the stimulation. A faulty measurement in the relatively short proximal segment by a few millimeters can result in a large miscalculation of the nerve conduction velocity occurring. This might in turn mean that an incorrect pathological result can be shown. Motor neurography of the median nerve, registration of F-wave. The recording of the F-wave is clearly shown by the example of the median nerve. The placement of the recording electrodes is similar to the motor neurography of the median nerve. Thereby, the active electrode is stuck on the abductor pollicis brevis muscle. Meanwhile, the inactive electrode is placed on the respective enthesis, the anterior thumb joint. The grounding strap is fixed at the wrist between the stimulation and recording electrode. In contrast to the motor neurography, the stimulation electrode is placed on the wrist above the median nerve. This ensures that the cathode, which is the minus electrode, points to proximal. The current intensity is gradually increased until the amplitude of the voltage of the potential does not continue to rise. The current intensity will then increase by an